Welcome to the Memorizing Pharmacology podcast. I'm Tony Guerra, the pharmacist and author of the Memorizing Pharmacology book series, bringing you mnemonics, cases, and advice for succeeding in pharmacology. Sign up for the email list at memorizingpharm.com to get your free suffixes cheat sheet, or find our mobile-friendly, self-paced online pharmacology review course at residency.teachable.com/p/mobile. Let's get started with the show. Hey, welcome to the Memorizing Pharmacology podcast. We're going to be talking about GI case studies today in pharmacology. I'm Tony Guerra, your host, and let's just get started. So we're going to actually go all the way to 7.3, which is our critical thinking activity. A patient who underwent surgery recently has a medication order for daily pantoprazole. The nurse reviews the patient's medical history and finds no history of GERD or peptic ulcer disease. The patient does not report any symptoms of heartburn, stomach pain, or sour stomach. The nurse reviews the physician orders for an indication for this medication before calling the provider to clarify. What is the likely indication for this drug therapy for this patient? So let's start there. Okay. So this is an excerpt from Memorizing Pharmacology Relaxed Approach 2nd edition, and we see pantoprazole is here with the brand name Protonix. Many students will only memorize the generic names because that's all that's going to be required on, for example, the NCLEX, but it actually there's two reasons to memorize brand names. One, it's easier to know what it's for. And two, if you've ever tried to remember somebody's name and you try to remember their first and last name, it's always easier. So when I'm taking roll for the class, and we start classes again here in January, I'm going to always put the first and last name, and I'm going to take the time to learn their first and last name. And although I'll probably only address them by their first name, it just is so much easier for me to remember their name with the first and last. So here we are in pantoprazole, Protonix. We see that prazole is the ending, and that's for a proton pump inhibitor, something that makes it so that we have less acid in the stomach. And the brand name is Protonix, so it nixes protons. That's where the name came from, or gets rid of protons. And pantoprazole, like esomeprazole or rabeprazole, comes in an IV form. But the most important thing is that now we know what it does, but we're not necessarily sure why it's there for this particular patient. So we know it stops proton pumps and that it reduces acid. So let's go back to that case. And the patient has no symptoms. They don't have heartburn. They don't have stomach pain. They don't have sour stomach. Why in the world are they on this medication? Well, the key is actually here. They underwent surgery. And because they underwent surgery, there's a stress response where they might get a stress ulcer. And by suppressing that HCl or hydrochloric acid, that's why we're using it. We're trying to avoid stress ulcers. Okay. All right, let's go on to the next one, antidiarrheal medication. Critical thinking activity 7.4a. A patient has been prescribed loperamide for diarrhea associated with gastroenteritis. Patient begins to complain of heart palpitation. What is the nurse's best response? And then we'll talk about 2, a child age 6 has diarrhea. The mother asks the nurse what OTC medication she can provide her child to help resolve the diarrhea. What's the nurse's best response? So let's go back to the book again. And we'll go to the antidiarrheals here. And we see loperamide, and the brand name is Imodium. So loperamide doesn't have an ending or a stem that's going to be useful. It's an amide, but that's just a chemistry term. That's not really going to help us. But what you can do is you look at loperamide and you see low, L-O, and then PER, which is the first part of peristalsis. So low or slow peristalsis is a way to think of an antidiarrheal that will slow down peristalsis and will help prevent diarrhea. Also, Imodium is like the word immobile, and it is really immobilizing the bowel for a little while to prevent that diarrhea as well. So 2 mnemonics there to help you remember it. So we go back to the question here, and what is the deal with the heart palpitations? We know that the patient is taking something for diarrhea. It's meant to actually create a more constipating effect. But now we know what to do. Now we know what to look for. And there is a black box warning on loperamide that an abnormal heart rhythm can happen. So the nurse will do an assessment. We want to make sure we understand heart rhythm and heart rate. And then obviously contacting the provider is key to provide those results. Now, this age 6 child, it kind of depends. If the child is having severe multiple diarrhea, over the course of the day, that's a very different thing, where the patient might become very dehydrated, and that's a real concern. But if this is just a one-time thing, maybe we're thinking about something like adding yogurt, which is a good source of probiotics, or something like that. It just kind of really depends. And the big thing I want you to take away is that diarrhea is not a disease. It is simply a symptom. And so if it is a symptom, something else is probably going on. If it's just the one-time thing, no problem. A little yogurt, that's fine. But if it's happening more than once, we really want to kind of think about contacting a provider. Let's go to 7.4b. Okay, so this is our third of the 4 cases we'll do today. Patient underwent hip surgery 2 days ago. Has not had a bowel movement since before admission. The patient is receiving OxyContin ER 10 milligrams every 12 hours and oxycodone 5 milligrams every 4 hours for pain. Patient describes abnormal discomfort, and the nurse finds decreased bowel sounds in all quadrants. Nurse notifies the physician, follows the bowel protocol, and administers docusate sodium to the patient. 1, what are the potential causes of constipation that should be addressed for the patient? 2, what is the mechanism of action for docusate? 3, the patient asks how quickly the medication will work. What is the nurse's best response? 4, what other preventative measures for constipation should the nurse teach the patient? And then if docusate is not effective within 24 hours, what other medications can the nurse anticipate to be ordered? All right, so got quite a bit to unpack here, but let's kind of go back. So this is a bit of an error to put the not caps here to show that OxyContin ER is a brand name, and this is a long-acting opiate, and then oxycodone is a short-acting one for breakthrough pain. So you've got a long-acting opiate and a short-acting one. And that amount of opioids is certainly going to cause issues with constipation. So we've kind of got what's going on with that. So the opiates for sure. And there might be some side effects of anesthesia, the fact that they're not really moving around, they're sedentary, and that you're not really going to take a ton you're not going to drink a ton of water, eat a lot of food just after surgery. So all of those things really kind of come together to necessitate this docusate. So the potential causes of constipation that should be addressed, the opiates, are we using the lowest amount possible? Are we adding the docusate? Are they taking it on time, and so forth? How does the docusate work? Well, it really helps to kind of go back to the mnemonics here. And with docusate sodium, you would want to think of docusate rhyming with penetrate, because what it really does is help water penetrate the bowel and soften the stool. That's how it works. And then you can also think of the brand name Colace that improves the colon's pace. So again, I know that you don't have to have the brand name for many of your exams, but it makes it so much easier to know what this is for and also remember how to use it. But going back to that question, docusate softens the stool, and then that way we're going to get more bowel movements. This is a real disappointment for patients. How quickly does it work? It can take half a day, but it can also take up to 3 days. And the patient will likely have been given this pretty quickly, but they're going to be a bit uncomfortable for a while, and they might be asking for something more rapid. And it's tough to say, well, right now we're just going to kind of stick with this, make sure we're drinking enough water, making sure we're moving around and doing those things. But this is the gentlest, kind of best way to work with these constipation issues. So the other preventative measures that for constipation would include, kind of increasing that fluid, increasing the fiber, moving around, and again, using the fewest, opiates that you need to still provide, pain relief for the patient. And then how do we know when to kind of go with Docusate? So if it doesn't work in a day, well, it can take up to 3 days, but you can add something a little bit stronger, maybe like bisacodyl, suppository or something like that, which would only take an hour or two. Or you could use an enema, and those go 15 minutes. But really, a little bit of patience here is really good, because something's really happened. You really just kind of need to get moving around, need to make sure you get the water in, and then things can kind of get going again. Last one, 7.5, antiemetics. So critical thinking activity 7.5. A nurse is caring for a patient who underwent surgery earlier today and is experiencing nausea and vomiting. The original post-op orders included prochlorperazine, but the patient continues to experience vomiting despite receiving this medication. Nurse calls a provider, receives a new order for ondansetron, orally dissolving tablets, 8 milligrams 3 times daily as needed. 1, how will the nurse assess for symptoms of dehydration? 2, when administering the medication, the patient states, this tastes terrible. Why can't I have a normal pill to swallow? What's the nurse's best response? And then what other measures should the nurse teach the patient reduce the feelings of nausea and avoid dehydration? Okay, well, let's take a minute to unpack this. We'll take a minute and go back to memorizing Pharmacology. This is the Kindle book, but most people like the audiobook. They got the British narrators. We'll start with prochlorperazine. Okay, so prochlorperazine is compazine, and it's a phenothiazine that we used as an antiemetic. Again, it really is more about making sure that the patient understands what the medications are for and what we're trying to do. But ondansetron is that next step up, and the ondansetron does have that ending, the citron ending, and you may see ODT, which doesn't taste bad because it's an orally disintegrating tablet, and that's a choice that might make things a little bit easier for someone that's so sensitive to taste. It does affect the neurotransmitter serotonin, which is located in the GI tract. And it's kind of neat that in the word ondansetron, if you're one of those people that likes word scrambles, it's got every letter but the letter I from serotonin, which might have been how they named it. So going back to the question, so now we know these are 2 antiemetics, kind of doing a stepwise process here. The first thing we would do, making sure that the patient is not dehydrated. We want to check what their, make sure they're not hypotensive, make sure their heart rate is not tachycardic, make sure that they do have, a good urine output, and then check the skin for tenting, and then, checking the mucous membranes for dryness. Any or all of those can kind of let us know, okay, where are we looking in terms of dehydration? In terms of, the taste terrible, if they have a tablet that dissolves, the ODT, that makes it a lot easier for the patient, and it really does dissolve super quickly. And then what other measures to reduce feelings of nausea, avoid dehydration? So sometimes if you give the medication before a meal, you may not have as much of an issue with the nausea. And then, kind of depending on the diet, if you're a little bit more on the bland side rather than the, kind of take out spicy side, you're in much better shape. And then again, more fluids is going to take care of the dehydration, but that also might make them feel a little bit more nauseous. So the speed at which you rehydrate them, making sure that they're maybe taking sips rather than just downing something to get rehydrated. Okay, so let's go back just to the book itself, and we'll kind of go here on Amazon just so you can kind of see. This second edition of Memorizing Pharmacology was meant to be more of a friendly textbook, as it were. Most people don't get the paperback. Most people get the Kindle because they like to be able to search. It's kind of nice when you're doing your homework, you're trying to find something. And that one's, I think, $10. But the audiobook, if you've never had it before and you just kind of want to get better at pharmacology, over the weekend or on the way to and from school, the way they work it is if you go to Audible or if you go to Amazon.com, and I own it, so it's not going to be up there, but they'll let you have it for free, and then make sure, if you don't want to be part of that Audible thing, you cancel within the first 30 days. But I found that a lot of my students, when they make pharmacology kind of part of their day, morning and night, because this is in a specific order, it starts with gastrointestinal, musculoskeletal, and so forth, that if they kind of keep hearing it and that they don't have this kind of jerky, I'm going to do some pharm on Tuesday, some pharm on Friday, or all pharm on Sunday night. That's what causes all of that anxiety. By doing a little bit each day and just kind of embracing it, I think it works well. So a lot of people will say, I'm not good at pharm. And what we really want to say is, well, I'm not really good at pharm yet. It's something I got from a chemistry professor here, which I'll have an interview for you a little bit later. But you're just not good at pharmacology yet, and it takes some time to do that. And it's really hard to do it if you're doing it once a week or twice a week, and that you're not really kind of embracing it and kind of listening to it each day and kind of getting the rhythm of it. Because what happens is that once you kind of get GI, you're still going to get a couple of other ones. For example, the musculoskeletal, you'll have talked a little bit about opiates because you're going to have to talk about how to deal with the constipation. And then when you get to the opiates, like, oh yeah, I remember when I was doing that GI chapter, I remember the medications for the opiates. And then, now you kind of get into musculoskeletal and you think about, okay, well, diazepam is one of those ones that affects muscles, but isn't that kind of used for seizures and stuff and neuro? And as you're going through each chapter, it just makes it a little bit easier for you. So again, I did spend a lot of money on a British narrator because I get it. Pharmacology is not the most exciting for many people. And by having that British narrator, it just kind of elevates it a little bit, makes it more pleasant to get through. So, all right, well, that's it for this week. The GI pharmacology cases, hopefully those are helpful for you. And I will bring back a new pathophysiologic class next week. Thanks for listening to the Memorizing Pharmacology podcast. You can find episodes, cheat sheets, and more at memorizingpharm.com. Again, you can sign up for the email list at memorizingpharm.com to get your free suffixes cheat sheet, or find our mobile-friendly, self-paced online pharmacology review course at residency.teachable.com/p/mobile. Thanks again for listening.